Mic's on. Welcome, everyone. Thank you so much for joining us today. My name's Pat Heinrich. I might know many of you. I'm the Executive Project Director here at NICHQ and been here for on and off for 20 years. Before joining NICHQ, I was a nurse with many, many years of experience working with babies and children and families. And now I have brought that experience and my quality improvement training to NICHQ to work on maternal and infant health projects, and most recently focusing on health equity. I've become very passionate about this and I'm learning more about it every day. Before I introduce our speakers, I want to set the image for everyone listening today, and that this is the first of 3 sessions we'll be holding. And we hope these can be really safe and honest walks that we'll take together to reflect on our individual roles in addressing health equity. I know you're calling in from all over the country, so some of you may be in snowshoes, others may be in mud boots, but we'll walk together and think of this as the first webinar, really a safe place for you to begin wherever you're starting. Thank you so much for joining us, and thank you for your colleagues for setting aside the time and having the courage to start right where you are on this journey of reflection, learning, and action. So during today's webinar, our 2 speakers, Dr. Elizabeth Cote and Dr. Stacy Scott, will be having a conversation with us, and they're going to be talking about health equity and its effect on children's health. They'll talk about the work we do as individuals and what we can do to begin to address health equity in our projects that we're working on. While the goal of equity and the concepts are shared and promoted by NICHQ, these personal stories that Stacy and Elizabeth are going to share, sometimes under aliases, really are their own stories and not meant to reflect the values of NICHQ. They're really opening themselves up to support you in your work and reflection. So, Elizabeth?
Thank you, Pat. And thanks to each one of you who made this topic of health equity a priority in your day today. My name is Elizabeth, and I started noticing health disparities pretty early in life. It has shaped who I am personally and professionally. When I was 14 and my sister was 7, she jumped off a swing and externally fractured her elbow. And between sobs, she cried, "Mom, can't pay for the hospital." In that second, my social conscience crystallized. I became a doctor and a health policymaker. I've worked abroad in India, Haiti, and Iraq, and most recently as clinical director for a Native American tribe. Now, as NICHQ's Chief Health Officer, I spend every day working with great colleagues to address disparities for children all over the nation, children like my sister.
And Stacy?
I'm here.
Hey.
Hey. Yes. Well, I'd like to, thank you, Pat. I've been working in this area for quite a while. I'd say about at least 17 years. I worked as a community liaison with another federal agency, the Eunice Kennedy Shriver National Institute of Child Health and Human Development. And in that capacity, I worked with diverse communities across the United States. My biggest focus was promoting safe sleep messages in communities of color. I've had the opportunity to manage several national partnerships ranging from fraternities to sororities, from faith-based civic organizations, with one specific task in mind, and that was keeping babies' sleep environments safe and reducing the disparities and infant mortality. I'm now serving in the capacity as project director at NICHQ, which allows me the opportunity to put theory to practice. We are working to ensure that we are inclusive and equitable in all of the things that we do and all of the work that we are working in the community, again, in an effort to eliminate disparities. and promote health equity.
Thank you, Stacy. So now you've all met my two teachers, and I hope you'll realize how much I've learned from them by listening to them throughout this program. So our objectives for this call today, this webinar, are on the screen. You can see them. We're really hoping to define and contextualize health equity and health disparities. We're going to explore implicit bias and how it influences our actions. Elizabeth and Stacy are going to model a hands-on approach for exploring that and share with you a strategy that you might test as soon as this is over. And we'll provide other specific steps you can take to examine and address your own implicit bias. One of those will be the oops, ouch role-playing exercise that they're going to do later in the webinar. But before we start, I'd like to just provide a quick background about NICHQ and why we're so passionate about this topic. NICHQ is a nonprofit organization that for nearly 20 years, yes, it's our anniversary, we've solely focused on driving dramatic change in the complex issues facing children's health. What motivates us is really our mission and vision. This is the heart of our belief that children and families deserve really a much better system to support everything that they get from their health and health care. We want really every child to reach their optimal health. And because of this belief, addressing social determinants of health and eliminating health disparities is really central to our mission. I'm sure you've read in the newspapers that this is just becoming more and more a problem in the United States. And so this is more and more important to us as we go forward with each of our projects. Our current initiatives include early childhood, children with special health care needs and chronic diseases, and perinatal and infant health. And the necessity of building health equity to improve children's population health is really illustrated in every single improvement project that we take on, from reducing safe sleep, infant deaths, to empowering parents to be advocates for their children's social and emotional health. I'm now going to turn this over to Elizabeth to begin a conversation about health equity and its effects on children's health outcomes. Elizabeth?
Thanks, Pat. Today, over 3,000 people showed up on this call to take on the challenge of building health equity. And health equity may sound aspirational, but it's actually achievable. Getting there means we must understand health disparities, systemic inequality, and implicit bias, or stereotypes we may not even know we have. And this will involve personal discoveries, feelings of vulnerability, and unintentional missteps we did not expect. Stacy and I call these oops, ouch moments. I also like to call them lean in and learn moments. So think about this talk like a frank, honest conversation you're having with friends about an important but sensitive subject. We're taking a guided walk, though, exploring health equity. It's an unfamiliar, moderately challenging, and pretty brisk walk, but we'll be your guides. There may be moments when you want to stop and run back to your email. But the goal here is to finish the walk together, complete our walk around the health equity pond, even when you feel vulnerable, because the reward is growth, and through that growth, your work building health equity will become greater. Inherent to these conversations are learning moments. So that means if Stacy or Pat or I inadvertently say something that hurts you or offends you or just doesn't seem right to you, we are sorry, and we're very ready to hear about it. Are you ready? Let's go. As Pat said, we're going to start our journey with some basic definitions that grounds us all using a shared understanding. Studies show the very act of creating a shared definition of health equity helps groups engage more effectively in that work. So we're going to start with the basics, the definition of health equity. In a report designed to increase consensus around the meaning of health equity, the Robert Wood Johnson Foundation provides the following definition. Health equity means that everyone has a fair and just opportunity to be healthier. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. Now, a few more definitions will set the stage for today's conversations. Disparities. Disparities are differences between groups in status and outcomes. Disparities are often described in relation to socioeconomic position, ethnicity, race, geography, gender, and age, or as a combination of these and other factors. This is particularly true for child health disparities in the United States, which are routinely defined as a function of multifactorial determinants. Now, the distinction between the terms disparity and inequity is critically important. Whereas the term disparity only defines differences between groups, inequity describes the causes of disparities in the context of the social, economic, civil, political, cultural, and environmental conditions. Inequities result in disparities in health status that are unfair, unjust, and unnecessary. By definition, inequity is amenable to change. This is deep. Now let's take a look back at the illustration of health equity created by the Robert Wood Johnson Foundation. Child health equity requires more than giving the same bicycle or the same vehicle for health to every child, regardless of their social, economic, cultural demographics. It means meeting each family where they are in the context of their lived experience, so we can adapt vehicles for health to their social determinants of health and provide children with the vehicle each child needs to have the healthiest ride they can in life. This work is inspiring and innovative. We can build a lot of better bicycles, and there's no time to waste, since the reality is that unfair, unjust, and avoidable disparities in child health in the U.S. is on the rise. These racial, ethnic, gender, and class-based disparities have profound implications for the welfare of children in the United States and for the adults they will become. The sources of these disparities are deeply rooted in inequities in social and environmental determinants of health, like poverty, income inequality, maldistribution of educational and other resources, racism, and environmental injustice, and the failure of public policies to address them. The number of children being marginalized by our society is escalating, and child poverty and other indicators of children's well-being rank the United States among the lowest of the industrialized nations in the world. Health disparities in children are extensive, pervasive, persistent, and growing, and they'll remain prevalent until we address these determinants of health together through a shared agenda on child health equity. Why does child health equity matter? Let's look at some of the differences in health and healthcare among children caused by inequity. The American Association of Pediatrics Committee on Health Research published a technical report on racial and ethnic disparities in the health and healthcare of children. This technical report reviewed 781 articles published on children's health disparities. Of those 781 articles, the report selected and summarized the results of 111 peer-reviewed original research studies. Published in 2010, no review article has since summarized the entire body of evidence as the AAP report did. But the evidence continues to mount exponentially, and consensus is that disparities have grown. The charts from the database are shown here. Line by line, they list individual, unduplicated findings from those 111 studies. It's a litany of unjust, avoidable, unique disparities in the health of children. At a glance, and without reviewing 781 articles, you can feel the weight of the growing body of evidence and see the racial disparities in children's health and healthcare, that they're extensive, pervasive, persistent, and growing. In this report, disparities were noted across the spectrum of health and healthcare, including in mortality rates, access to care, and use of services, prevention and population health, health status, adolescent health, chronic diseases, special health care needs, quality of care, and organ transplantation. Mortality rate disparities were noted for children in all 4 major U.S. racial and ethnic minority groups: African American, Asian Pacific Islander, American Indian Alaska Native, and Hispanic or Latino. These disparities included substantially greater risks than white children of all-cause mortality, including death from drowning, from acute lymphoblastic leukemia, after congenital heart defect, and an earlier age at death for those with Down syndrome and congenital heart defects. An African American child born with Down syndrome is likely to die 25 years sooner than she would if she had been born white. An Asian Pacific Islander family must worry that their child is 3 times more likely to sustain a firearm injury. Latino girls aged 15 to 17 are the most likely of all ethnic groups to become young mothers. And Alaskan Native and American Indians, the least studied group, are 2 to 3 times more likely to lose their babies to sudden unexpected infant death, the highest likelihood of all 4 groups. Eliminating health disparities matters to these children and their families. And eliminating health disparities would also make a significant difference in the overall population health of children. If health disparities in the United States were limited such that all children had the same risks of adverse outcomes as those of the most economically privileged, the prevalence of poor outcomes would be reduced by 60 to 70%. Let me say that one again. If all children had the same risk as non-impoverished white children, adverse outcomes like low birth weight, cerebral palsy, intellectual disabilities, child abuse, and disabilities caused by both intentional and unintentional injuries would be cut by way more than half. Okay, so to eliminate health disparities, we have to build more equitable systems. And the fundamental determinants of children's health and well-being, and subsequently the health and well-being of the adults they'll become, are rooted in social, behavioral, cultural, community, environmental, and policy factors that lie beyond the scope or purview of the healthcare system. But it all lies in your purview. You are a key player who lives in each of these systems. As health, educational, and community caregivers, you have a key role in mediating how inequity does or does not perpetuate disparities. Remember, health equity is amenable to change, and so are humans. Well, maybe we're not amenable to change, but we're capable of it. You are an important agent of change, and your ability to do this important work, increasing health equity and reducing disparities, depends on your own self-knowledge. So that's why we're starting today, beginning to build that self-knowledge. We're going to build health equity today by starting right where we are as individuals. I will pass this off to Stacy now to describe how to begin this very important work.
Thank you, Elizabeth. As Elizabeth shared, this is a big and complex. That's why today we're starting by working at the individual level. With each of you on this webinar, We're going to begin by learning how to identify and address our own implicit bias. So, what is implicit bias? Implicit bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. These biases can encompass both favorable and unfavorable assessments. They are activated involuntarily and without an individual's awareness or intentional control. Bias encompasses race, ethnicity, socioeconomic status, nationality, language, sex, gender identity, sexual orientation, religion, geography, and disabilities. It activates quickly and unknowingly by situational cues. For example, a person's skin color or an accent. It's silently exerting its influence on perception, memory, and behavior. It operates without a person's intent or awareness, controlling its own not straightforward matter. It justifies unfair treatment that can have long term negative impact on the targeted physical and mental health. Even when we understand implicit bias, it can still be difficult to recognize in ourselves. A big part of this webinar is to help you consider what you can do in your own lives to explore your implicit bias. To help, we are going to move into some examples and modeling on the internal work we can do to address our individual implicit bias. I am going to pass this over to Pat, who will moderate this section.
Thank you, Stacey. Thank you so much. So for the next part of the webinar, I'm going to be asking Stacey and Elizabeth some questions about the work they've done to recognize implicit bias, both when they experienced it and when they felt affected by it. We're sharing their personal stories because they want to demonstrate just how personal this work really is. We have to show up for it as our most authentic selves, and we have to engage in these conversations. In addition, we have to have a willingness to be vulnerable. We have to expect of ourselves and our colleagues a spirit of generosity, to assume that we trust each other, and we have to all be working towards learning together. I really hope that Elizabeth and Stacey's stories will help you reflect on your own experience and the conversations you can begin to engage in with your colleagues. You asked us to bring you practical strategies, and we hope we're doing this with these examples we're now going to talk about. Okay, so one thing I just want to mention, that while Elizabeth and Stacey are sharing their stories, we always ask you to do some work when we bring you quality improvement strategies. And so I would ask you to think hard while they're talking. Think about your own experiences with the same questions. If I were asking you, for you to reflect on these things, as Stacey and Elizabeth answer, tell us what you're thinking. Jot it down with a pen and paper, and we'll be coming back to you after this webinar to ask you to share that information. Consider these notes a placeholder and a prompt for you to return to and talk about with your colleagues and your friends, maybe even your family. At the end of the webinar, we'll be returning, as I mentioned, asking you to contribute those to a storyboard we'll be developing. All right, let's begin. Elizabeth, would you like to start with our first question? When in your life were you affected by implicit bias?
Sure, thanks, Pat. Being an advantaged white majority female, I was really surprised when I ran smack into implicit bias. I have 2 young daughters, and after I divorced my husband, I stopped wearing a wedding ring. And when I did this, people I interacted with started treating me differently. Store clerks that used to be patient now became irritated when I took longer in line because I was juggling 2 toddlers. Fewer parents would strike up conversations with me at the park where my children played. And when I became a single mother of 2 children and no longer had that proof of marriage, the wedding ring, I lost some of the privilege that I had unknowingly been experiencing. I fell into a stereotype of a single mother, and people began to treat me differently. Their implicit bias changed our interactions. And I think the bias I experienced might have been compounded by my children being of mixed race. So I put a different gold ring on my left ring finger, and people resumed treating my children and me with the privilege we had enjoyed before.
Wow, Elizabeth, you must have been shocked. Must have been really an unexpected and tough realization. Stacy, I'm sure you've had some tough moments too. Would you like to share a time in your life when you were affected by implicit bias?
Yes, Pat. I, I was born to a 19-year-old single Black mother in Los Angeles back in the 1960s. I can't quite pinpoint when implicit bias really kicked in for me, but based on what my mom tells me about her experience during her pregnancy, I can guarantee that the impact helped form the person I am today. It's funny, as a child, um, you really don't know what you don't know. My mom attempted to shield me, but no matter how hard she tried, reality soon set in. It starts so early, it's so hard to comprehend. As a Black woman, I wanted to believe that my daughter would not have to experience what I did. But I can remember when she was around 4 years old, we were on the playground and she wanted to go to get on a slide. And she kept hesitating. And I asked her, what's wrong? And she told me she couldn't. And I asked her why. And she said that there were only white kids on the slide. Despite all I had done, I knew that at that moment she had fallen prey to internalized racism. Already she felt the impact of implicit bias. Already she knew that things for her felt different than it did for white children. She knew at 4 that she would be treated differently because she was Black. As an African American mother, I have to tell you, I was very disheartened. I wanted to believe that the next generation, my children, wouldn't have to feel the way I felt my whole life. Now I hear stories from my friends and family who work in corporate America. I hear about the biases they face. A good friend's daughter, who I know works for a very large corporation, was just recently promoted. And after her promotion, another woman felt passed over for her position and made it clear that she felt that the only reason why my friend's daughter had that position was because she was Black. So for her, this bias meant that her skill set was negated and she was just a number to fill a quota. All this to say that implicit bias is everywhere for Black women. We experience it every day, and it can make you question every experience you have and wonder, is it affected? Am I being affected by biases? It can make you feel paranoid, and it's just not a healthy existence.
Oh, Stacy, that's so hard. Thank you for sharing. Thank you both for sharing your lived experiences. Our next question for reflection is, when did you first recognize your own implicit bias or that you were acting on your bias? I know we asked many people to take the implicit bias test before the event, and I hope some of you had a chance to do that and realize where you're at on that spectrum. But Stacy and Elizabeth, tell us about the moment you recognized it, or was it an active reflection? How did that happen, Elizabeth?
Okay, Pat. My biggest aha moment came during a conversation with Stacy Scott, actually. And like a cartoon, when a light bulb suddenly turns on over the character's head, I suddenly realized that years earlier I had let implicit bias systematically affect my actions as a resident physician in a large city hospital. So before this conversation with Stacy, I felt that I knew all about implicit bias, that I was sensitized to it, and that my education and trainings had me covered. But now I know that as a white majority female, I cannot rely on any implicit bias spidey sense. There's just too much I don't know and too much I haven't lived. And to address that unavoidable bias, I can only depend on my willingness to lean in and learn and to have these conversations. So one day, as Stacy and I were having one of our walks around the metaphorical health equity pond, she shared with me the archetype of the strong Black woman. As I understand it from Stacy, African American women feel internal and social pressure to act strong, to suffer quietly, to present themselves stoically, and often underreport their pain or distress. What she was teaching me transported me back to the days and nights I spent as an anesthesia resident in a big city hospital, and what she shared did not shine a very flattering light on some of the actions I had taken. As anesthesiologists, part of our job was to administer epidurals to mothers in labor and respond in a timely manner to place, replace epidurals, and adjust dosages depending on pain, self-reported pain. When Stacy was talking to me, I realized that in many cases, the decisions the anesthesia team made were influenced by implicit bias. If an obese woman or a minority woman or a woman with a history of drug abuse requested pain relief, the anesthesia team, including me, may have taken longer to respond. We may have resisted taking cases where body habitus made placement difficult. We may have underestimated the pain of Black women when Stacy taught me I should have adjusted my assumption the opposite way. And we may have doubted a mother with a history of drug use who reported an ineffective epidural, resisting replacing it. So when I reflect on this with Stacy, I can see how implicit bias, unconscious stereotypes, influenced my actions. And I'm sorry for my role perpetuating that because it probably caused unnecessary suffering, the opposite of my goal in life.
Thank you for sharing that, Elizabeth. And very powerful story that helps us really see how implicit bias changes actions and ultimately affects the health outcomes. We really appreciate your being so willing to be so open and transparent with your story. Stacy, let's go to you. When did you first recognize your own implicit bias or that you were acting on your bias? Did you recognize it in the moment or was it really an act of reflection?
Well, that's a difficult question to answer. Growing up Black in America during the 1960s, my parents taught me early on how to navigate and survive the powers that be. My parents' bias became my bias before I even knew what bias was, which means that as a Black woman, I often had implicit bias towards white people based on my lived experience. It gets back to that paranoia I mentioned before. Because I live my life always on a guard against bias, my own implicit bias tells me that I always need to watch my back. I always feel that if something goes down, it's going to be the Black person. That's how I feel. I have a wonderful relationship with white moms. I'm sorry, with white women, but I've had a hard time trusting them. And it takes longer for the relationships to form. That's my implicit bias. But I wanted to make it clear that we can change this. It just takes time and effort to develop that trust. But please know that it doesn't happen overnight.
Thank you. Stacy, and thank you both for sharing your experiences. Together, understanding that we all experience implicit bias really is an important grounding for all of us in this work. And we really hope Elizabeth and Stacy's stories help you all realize that every one of us has bias, experiences bias. And now we're going to move forward with some concrete steps that you can take as individuals to really address implicit bias when you recognize it. It's not a simple solution, but we really expect that these strategies will help you. So, Elizabeth, you want to start off?
Sure, Pat. Thank you. Like Pat said, this isn't easy work, but there are things we can do to help minimize our bias. First, what we're doing right now together, we can acknowledge that we all have implicit bias. Our brain makes shortcuts for us called heuristics. The brain recognizes patterns based off what we see and our experience, our environment. And we develop subconscious neural connections that influence our actions. Right now, we're operating on centuries and centuries of compounding assumptions skewed by bias that shape our experiences and influence how we act, even when we're not aware of it. This is only to say that we're human, not bad people. But many of these brain shortcuts that we formed based on what our parents have told us, based on our perceptions of history, based on what we watch on TV or what our neighbors say, many of these brain shortcuts don't serve us anymore. Now, how we address those biases, that's on us. We have to be courageous enough to explore our implicit bias, find our aha moment, and then, instead of fleeing, inquire and act. Stacy?
And second, you need to challenge your current negative bias about specific groups with contrary or positive information that goes against negative stereotypes. And number three, be empathetic. Many people may not have friends who are Black or Latino or LGBTQ or differently abled. It's harder to be empathetic toward them when, excuse me, you have no connections and you find ways to learn more about racial and ethnic groups you do not interact with. And you can do that by reading a book or watching a movie or a documentary. These things are important as you move toward addressing these biases that you have. Number four, see differences. The idea of being colorblind actually negates or minimizes a person's lived experience. If we don't find opportunities to learn more about others' historical and marginalized groups, we miss opportunities to make friends. And number five, be an ally. When you get an opportunity to be able to help people that you feel are being discriminated against based on some stereotypes, you need to step up, not be afraid, but being an ally or an advocate for people experience biases helps us create positive experiences for ourselves and for them as well. And number six, recognize that this is a stressful and painful. As I said, it is not easy. The natural reaction to an uncomfortable moment or conversation is fight or flight. Try to stay present, breathe deeply, stay inquisitive, and you will counter your stereotypes.
Finally, engage in dialogue. Finding your own aha moment is critical, but sometimes it can be difficult to register. And that's why I recommend talking through this with a trusted friend who has a different perspective, like I did with Stacy. Ask that person, how does it feel to be you in the health system, understanding that they're responding for themselves, not the entirety of a group of people who share a characteristic with them. And after you ask that question, stop and really listen to their response and ask yourself, could I have contributed to the bias that they've encountered? Finally, remember that these conversations do require courage because it's very deeply personal. The oops, ouch approach can help us in having these conversations. The oops, ouch approach asks that we start any conversation from a mutual assumption of the good intention of the other, so that when something offensive or hurtful is said, it is addressed in that context, rather than one of blame and shame or fight and flight. Specifically, if someone feels hurt or offended by another person's comment, they say, ouch. And this is a code word that the community understands, like a red flag. In response, the person who made the hurtful comment responds by saying, oops, in return. This is expected. They did not mean to make the injury that they just made. It sounds simple, but this approach allows us to share our concerns in a way that protects us and our egos, but allows us to keep connecting, conversing, and learning.
Well, we all realize this is easier to describe than it really is to do. So one of our goals today is to give you the tools that help you to really put this into practice, to have these hard conversations in your own life. So to that end, we've developed a brief role play exercise that will help you imagine what these conversations actually sound like. The conversations we're role playing is fictional. We made it up. But it's based on real things that Elizabeth and Stacy have seen and we've all heard or seen in our work. For this conversation, Elizabeth is going to be playing a white healthcare professional named Linda. This is where the aliases I mentioned earlier come in. So she's Linda. And Stacy will be playing Sloan, her African American colleague. Now, remember, you have to work to help you yourself learn this. So as you listen through the role play, really consider what parts of this conversation sound familiar. Imagine what you yourself would do in this situation. If you were Sloan or a bystander watching Sloan and Linda, how would you feel? How would you comment? How would you act? Would you comment or would you be quiet? Would you be present or would you tend to walk away? So let's turn it over to Sloan and Linda and have you guys play out our oops, ouch role play approach.
Sloan, I need some help understanding something. I know that your experience is not representative of all Black women, but I know your perspective can help me with a challenge I'm experiencing.
Well, what's going on?
It feels like no matter how much I talk about the importance of putting babies to sleep on their backs, Black moms don't get it.
You're saying they don't get it, and why are you saying that?
Well, don't get me wrong. I'm not saying that they're not trying or not caring, but I keep telling them what they need to do, and it's like it goes in one ear and out the other. Maybe their lives are too chaotic for it to sink in or be a priority.
Oh, well, you know, I hear you talking, and I just, again, I'm just kind of concerned and going, oh, maybe, ouch, you're just sounding a little bit biased to me. Being a Black mom myself, I would be somewhat resistant to the message. It's more about you not just telling me what to do, but maybe talking to me about, what are some of the barriers I might have in trying to achieve what you want me to achieve.
Okay, Sloan. I'm sorry. I didn't mean to. I'm not quite sure what you mean yet, though.
Well, look, Linda, I know you and I know you care about all moms. I know you don't want to be biased, but some of the assumptions you are stated may be the very ones that you are unconsciously making it difficult for you to partner with Black moms on safe sleep.
Okay, but all I'm saying is that when I have a conversation with a white mom, they seem to get it.
Well, there you have it. First, you said you were telling Black moms what to do, but now you're saying you're having conversation with white moms. Mothers like you and me want to be good moms. So it doesn't feel great being told you aren't doing it right. Why can't you have conversations with Black moms the way you do with white moms?
Oops. I'm sorry. I see how that definitely came out wrong. But I'm still having a hard time seeing how I'm being biased. I mean, I'm trying to give the same sleep information to everyone, Sloan.
Well, I got you, but assuming that Black moms' lives, are chaotic or that their baby's safety is not their number one priority, I think you are making assumptions. Most moms' lives are chaotic, but every mom's experience is different. Instead of starting with your assumptions, start from a place of inquiry. Are you asking Black moms what might make putting their babies on their back to sleep easier or more difficult for them? Are you asking them what priorities are as their baby's number one champion? Can you empower them to address some of the cultural and social and economic barriers to safe sleep practices that you may not even be able to imagine without their help?
Wow, Sloan. I feel embarrassed and I'm really sorry. Thank you for talking to me about this because I was super unaware of what I was doing.
Well, this conversation is just one example of how we can work with each other to begin to address our own implicit bias. We hope it's something that you can consider in your conversations as you begin to change your own assumptions and challenge them. Let's move on and talk about one more resource that we wanted to share. And I mentioned this at the beginning that you might have gotten in the email. We would welcome you to take this test before the webinar today. And even if you didn't see that and you didn't have a chance, we'd like to share this now, the Implicit Association Test, or the IAT. This is a series of 14 tests that measure, you don't have to take all 14, don't worry. I heard the heartbeats go up. But this is a series of 14 tests that measure the attitudes or stereotypes we subconsciously associate with different concepts like age or race. And we know that it can really help you learn about your own bias. I took more than one of these myself, and I really went into it thinking, oh, I don't have any bias. I'm not biased. And yeah, well, that wasn't exactly true. So it's really an eye-opener. It really will help you recognize your own bias. And as Stacy and Elizabeth explained, recognizing that bias you have is really critical to starting to change how you treat your patients and your moms and babies and families, and move forward and learn as we hope we all do together. So what's next? Today, Stacy and Elizabeth shared their experiences and some relevant resources that you can begin to explore in your life and work, teaching you more and more about implicit bias. While you do this, we hope you will engage with us in this conversation. It has to be two-way, it can't be one-sided. And that's why throughout the presentation, we've asked you to reflect on your own experiences. We've asked you to think about how you would address these issues, what you have experienced, what your reflections are. After the webinar, we're going to send you an email. You know, the story with NICHQ is once you're attached to NICHQ, you're never unattached from NICHQ. And so you will be on our email list, and you'll be hearing from us right after this event. We'll send you the slides and the recording in case you want to listen again. But would really like to ask you if you will join us in this conversation by sharing your stories with us. Anything you would be willing to share, we would be welcome to hear. A story about how implicit bias has affected your health, your own well-being, your children or your family, your friends, your colleagues. Any story of your own aha moment, a time when you realized you were biased, or a time when you might have intervened in a situation that you saw bias. We really would like to hear all you have to share with us. We're going to take those email replies and create a storyboard of experiences. Don't worry, that'll be anonymous. We won't use your names, but we'd love to share those with others on the next webinar in this series. We mentioned this is a 3-part series, and we will do that in the next part. We'll be building the storyboard of experiences, and we'll be developing a collective understanding of how pervasive implicit biases effects are, and also how every individual has a responsibility to recognize it and address it. And then as we move forward, we'll be talking more and more about other strategies you can use. So we now have some time for questions. We're going to open the webinar up to question and answers. Please type your questions in the chat box, and we have had quite a few of those coming in so far. Let's see. So one question. I heard an articulate, educated, affluent Black woman share her experiences as an OB patient at her physician's office and the negative response she received from the front staff purely because she was Black. How would you ask women of color to advocate for themselves that when they're pregnant and they're treated in such a manner? Stacy, do you have suggestions you might want to share?
I think the biggest thing, and it's difficult because, you know, who do you have to again advocate for you, and if you don't know what you don't know. But I think it's again that having an ally present, having somebody to understand that they can intervene. But as a Black woman, it's really being well educated and understanding, you know, what your rights are as a patient. And I don't, let me take that back, not real educated, but being to know that what you should not take. And so I can give you an example. We do a lot of work in Detroit, Michigan with moms. And it's amazing that when we bring them all in together, and these are moms that, you know, are having some difficulties in their life. And it's so unfortunate because no one's really educated them to say, if this healthcare provider is not, you don't feel is operating in your best interest, that you have the ability to seek out someone else to provide you service. So it's a difficult question, and a difficult way to answer it, because if we as healthcare professionals or people work in this field don't give the knowledge and let women know that they are empowered to make those choices, we still are going to kind of see these same things happening. So I think it's from the very get-go that whenever opportunity to let people know that they do have a choice. And, you know, that it's very difficult to try to figure out where mechanisms that are out there to be able to empower these women to understand that they do have a choice and they just don't have to take anything, especially if it's not in their best interest.
I agree with that, Sue. And this is Elizabeth. I want to add on real quick that you only really need one ally. When I was working in a Native American tribal clinic, you only need one person. You don't have to re-explain your story and you create an ally out of everyone. So if as a minority person, you put in the energy to invest in one care provider, that provider can do volumes of work for you. So when one of my American Indian clients would confide in me what was really going on, I would call their other providers and advocate for them. So find one ally, invest in them, which is going to take, it's work that I wish you didn't have to do. It's unfair, it's unjust, but then have that ally work for you because they know what standards of care you should be receiving. And unfortunately, the folks that aren't confronting their unconscious bias are going to be more able to listen to that ally that you cultivate.
Thank you so much. So another comment we have from Natasha is that the minorities in the previous slides were all compared to wealthy white people. Is not poverty alone a major issue that people of all races experience? She's not understanding that, not underestimating that there's also racial bias, but she's heard many minority speakers state that they see poverty as the main reason for implicit bias, and I certainly can agree with that.
Yeah, I'm sorry. I actually, I should have clarified from those slides that while a lot of the comparisons were just against white children alone, the most stark differences are when you, and we did say it's multifactorial. When you divide out for white economically advantaged children, I do think poverty is one of the largest disparities that we face, and income inequality underlies a lot of what's going on. However, there's much more to the experiences based on the other social demographic factors. And you might remember that startling statistic that if every single child had the same odds of an adverse event as a wealthy white child, poor outcomes would go down by 60 to 70%. That's a much healthier population of American kids. So that's something we have already accomplished in this country. It's just something that not everyone has, which means it's unjust.
Thanks, Elizabeth. We do have a question about where to get that test. We will send that link around again for people that are wondering about that. And I just wanted to add one more thing to Nancy's question about the treatment by the front desk staff. Many prenatal patients, excuse me, have a long-standing and wonderful relationship with their OB. And I wouldn't hesitate to talk to your doctor about how you were treated, or to encourage your moms to talk to their doctor, because I think sometimes, these front desk staff just really are so busy and overworked, and they just might not realize. And so again, this is a learning opportunity for them. We have a number of comments from David Mann. He posted in the chat about the 2020 definition of disparities as more than a difference, not just a difference, but defining health disparity as a particular type of health difference that's closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups of people who have systemically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination. And I think those are important and include some things that we didn't have in our list. So thank you for that. We have another question. Did you have the experience when you tried to talk to others that were having bias directed towards them and they told you to leave it be?
Yeah, I can definitely say yes. I mean, and this would be more in a professional life throughout the different jobs I've had over time, that I try when I recognize bias to be an ally, which is something we talk about. But the first step of being an ally is to ask permission to be an ally, because I think that you can't co-opt someone else's experience and presume what they want to happen in that case. And while you might be outraged, you might not realize the entirety of the impact of what your planned intervention is. So a lot of times the best way to be an ally, the first step of being an ally, is to quietly on the side tell that person, and I've done this in a waiting room when I've seen a minority patient and I'm just another patient be treated poorly by the front desk, and say, you know what's happening to you? I see it, and it's not fair. So just by validating, you don't even have to take another step. That's the first step. And then you can ask, do you want me to do something about this? Do you want me to help you do something about this? But you got to ask permission.
Thanks, Elizabeth. So now I'm sorry to say that it's time for us to close the webinar. I think we've had a wonderful conversation, and we have so many really wonderful questions in the chat. I'm sorry for those of you that had some trouble signing on. We're glad you were all able to come on. Again, we will share the link. We will share the slides and the recording. And we will also commit to you to getting some feedback about these questions. We've got some folks answering some of them. Some of our family partners from our projects are speaking right up and answering some of these for us. But I'm sorry, our time is up, and we do need to end. Thank you all for participating, and we look forward to you joining on our next part 2 health equity webinar. Have a wonderful evening.